Hi, everyone. Thank you for joining today. Today, I'll be talking about the approach to the immunocompromised critically ill patient. I'm an infectious diseases physician and critical care medicine physician practicing at Massachusetts General Hospital. I have no disclosures related to today's talk, but I would like to thank some people who contributed material for this talk. First, I'll start with my take-home points. So some of the things I want you to take away from today's talk is the concept of the net state of immunosuppression, which I'll go through in greater detail, considering all contributors to your patient's current immunodeficient state. I also want to point out that the timeline really matters when we're thinking about infections in the critically ill patient, and that community-acquired infections become much more common than opportunistic infections and nosocomial infections beyond about 6 months after transplant, especially. I also want you to take away that sepsis is a leading cause of death in immunocompromised hosts, that pneumonia risk persists for many years after transplant, and that you really need to have a high index for suspicion in your patients because immunocompromised hosts may have more subtle presentations than other patients. Remember that common things are still common, but have a low bar to treat empirically for multi-drug resistant organism infections in your immune-compromised hosts. You should have a lower threshold for more frequent and higher grade, especially cross-sectional imaging to diagnose infection, a much lower threshold for invasive diagnostics in your immune-compromised host compared to others. And remember that prevention is key, and many of those opportunistic infections can be prevented. So here's a brief outline of some of the things that I hope you'll learn today, and the outline that we'll go through for the rest of this talk. So first, I'll talk a little bit about some of the types of immunodeficiencies that we see in our patients who are critically ill. I'll talk about this concept I mentioned about the net state of immunosuppression and how we can predict a patient's risk of certain types of infections. I'll go through the timeline of infection risk and what presents at each different time, some of the common critical illnesses in transplant patients, including sepsis and pneumonia. I'll do a little review on the diagnostics, especially for fungal infections, and some things about treatment, including drug interactions, which are very important to consider in your patients who've had transplants. So firstly, let's talk about some of the types of immunodeficiencies. So these are the broad categories of immunodeficiencies. I won't go into each of them in detail. Primary or congenital immunodeficiencies are still occurring in adult populations, so you should be aware of the fact that they could exist in your patients. Secondary immunodeficiencies are much more common. We do see patients with HIV and AIDS or AIDS-defining illnesses in our critically ill population. I think even more common these days, we see a lot of immunomodulating and immune depleting treatments, including biologics, which I'll talk a little bit about, and chemotherapy, which are often done in the same patients as well. We also do see some people who are asplenic. I won't really cover the effects of asplenia today, but you should also be aware that that can cause different types of immunodeficiencies than others. And of course, we see our transplant patients, so both solid organ and hematopoietic stem cell transplants. And I'll spend more time talking about those populations today because they tend to present more often in the ICU. So let's talk a little bit about this net state of immunosuppression. So the basic principle is really that the dose and the duration of suppressive medications, mechanical factors, and underlying host factors, including ongoing infections, really contribute to immune compromise. Epidemiologic exposures also really matter, both new exposures and remote exposures that could possibly reactivate. This net state of immunosuppression concept was really developed and pioneered by Dr. Robert Rubin at MGH many years ago, which was really considering immunosuppression or immunodeficiency as an additive or composite in any given patient of their risk factors, including their underlying disease state, which may alter the immune system, both autoimmune diseases and organ failure. Other comorbidities and conditions that we see commonly, including metabolic syndromes, hypogammaglobulinemia, which is often underdiagnosed in transplant recipients, viral infections, especially chronic viral infections that can become latent, altered microbiome, and advanced age. Mostly what we think about, though, is exogenous immunosuppression, including both pre-transplant induction agents at the time of transplant, and chronic immunosuppression or periodic, required, for example, to treat rejection. So I want you to not forget these other categories when you're thinking about the exogenous factors. Also think about the underlying disease state and the comorbidities that could be contributing to a net state of immunosuppression in your patient. So really think about the risk of infection as a semi-quantitative relationship between that epidemiology and the net state of immune suppression, including latent infections that might be present. I want you to think about the epidemiology, both in terms of recent exposures and remote exposures that might be able to reactivate. So some of the recent exposures that we see in our critically ill patients include nosocomial colonization, which of course increases over time as people are in the hospital, urinary tract infections and aspiration, which are very common after transplant, after surgery, devices which may be implanted, including catheters that are temporary or longer term, like temporary dialysis lines, surgical complications, especially from the transplant itself, and then pre-transplant community-acquired exposures, which may rear up at the time of transplant. And Cryptococcus and Legionella are two of those, and anything that might be donor-derived, including multi-drug resistant colonization or infections that could come from the donor, some of which I've listed there below. Remote exposures can also come up and can contribute. Tuberculosis and non-tuberculous mycobacterial infections can come up after transplant as the immune system is ramping down and there's less control of those distant infections. And distant multi-drug resistant organism colonization can also come back and cause infection, which is one of the reasons why this population is at risk, higher risk for MDRO than other populations. Strongyloides is also something you should keep in mind in people from endemic areas, which includes much of, especially the southern United States and many countries in the world. Herpes viruses, which can become latent. Other viruses, which can be chronic, including hepatitis, toxoplasmosis, leishmania, and Trypanosoma cruzi. Also, endemic fungi can be remote and can reactivate. So this is just a brief list that you should keep in mind when you're thinking about both recent and remote exposures that could play a role in your critically ill patient. Let's talk a little bit about biologics because they are a hot topic and we see a lot of patients in the ICU who are receiving biologics as immunomodulatory or non-oncologic therapy. So unfortunately, it's a very broad category, and it really means any therapy that alters or suppresses the immune system can be called a biologic therapy. So it includes disease-modifying antirheumatic drugs, which are the classic biologic therapies, and they're used to treat a diverse array of autoimmune and other diseases in multi-organ systems, many of which I've listed there. Biologics are really these biologically defined products which are engineered to bind or interfere with specific molecular targets. The data that we have to rely on in terms of their risk in contributing towards infections really relies heavily on TNF-alpha inhibitors because those have been around for the longest time. I put in this table some of the different suffixes that are used to identify the targets for those biologics as a bit of a cheat sheet. So when you're thinking about biologics, you can really think about what the examples are and what they might be targeting. There is a long list of biologic therapies, and I've just provided a short list here of some examples. Many are also used in combination with other treatments, and it can be hard to parse out which agents are really the most active or contributing to immunosuppression and what their combined effects might be. So I listed them here, and I'll just go through a few in detail where we have better data. I will say that it's very difficult to establish causality between receiving biologic therapies and their effect on the immune system and the risk of infection. And that's for several reasons, including that the underlying disease for which the patient is receiving the biologic therapy may also affect the immune system and increase or modify risk. The mechanisms of action for those biologics also don't always predict the infection risk. And some infections are really rare and they come up late. And so it may be very difficult to identify whether the biologic really was a risk factor for that infection. Furthermore, biologic agents have a very long half-life, which makes it difficult to follow patients long enough. And most of the trials are really not powered for that kind of safety outcome. Also, people receiving biologics are often receiving either multiple biologics or biologics plus other drugs, which makes it very difficult to parse out the effects of each. and reporting is really inadequate. So with all those caveats, I just want to point out a few of the known complications. And as I mentioned previously, we have the best data for TNF-alpha inhibitors. So TNF-alpha inhibitors are associated with an increased risk of serious infection that's been reported in multiple studies. The overall risk is estimated at 4.5 to 14 per 100 person years. And amongst them, they're not all the same. So the highest risk in this category is infliximab, followed by adalimumab, and the lowest is etanercept. And then there's others that fall between. There are also many biologics that really don't have an increased risk of infection. I've listed most of them here, including anakinra, which is pretty common in our population, but it can be difficult sometimes to parse out, and I encourage you to seek out some of the tables I'll point you later in this talk so that you can look for your individual patient and see what their risk is. So many people I mentioned are also getting other drugs. So one of the drugs we often worry about is steroids. So multiples have studies over time have shown the same kind of effect. I like this particular paper, which really points out the risk of infection, kind of a dose-response relationship between steroid doses and risk of infection. So these are from Medicare and Optum data. So you can see in this table, table 2, the adjusted hazard ratio for people taking different doses of steroids. So less than or equal to 5 milligrams of prednisone per day still had an adjusted hazard ratio that was elevated for serious infection, so hospitalized infection. So here for less than 5 milligrams, the hazard ratio is still 1.3 to 1.4. It jumps when you go above 5 up to 10 milligrams per day to around 1.8 to 2.0, and then it jumps above 2 for those taking more than 10 milligrams. The results are pretty similar with the Optimum data, demonstrating that these are really robust to the type of patient mix, and this has been demonstrated in other studies. So I just want to point out that this is really an important risk factor to consider, and that even low doses have an impact, especially when they're combined with other medications to contribute to the net state of immunosuppression. So let's review some timelines now for infection risk, now that we've talked about immunosuppression generally. So the greatest immunodeficiency in transplant patient really occurs after solid organ transplant in the first year and after hematopoietic stem cell transplant in the first 2 years. For biologics, it's up to 2 years for many, but it kind of depends on both the biologic and the pharmacokinetic half-life. Let's start with talking a little bit more about transplant. So in the first month after both solid organ and hematopoietic stem cell transplants, nosocomial infections are very, very common, especially hospital-associated pneumonia and ventilator-associated pneumonia. Candidal infections are also common. And then moving towards a 1 to 6 month timeline, community-acquired pathogens begin to play a bigger role. And this is really where opportunistic infections start to come up, including cytomegalovirus, endemic and non-endemic fungal infections, and nocardiosis. After around 6 to 12 months, as immunosuppression or immunodeficiency starts to wane, community-acquired infections really start to dominate the picture. Opportunistic infections can sometimes still be seen, but donor-derived infections and contamination of the allograft or perfusate become very rare. Let's drill down a little bit more on that and talk about the first month after transplant. So infections transmitted with donor organ or cells are very common. Infection or colonization that was actually present in the host prior to transplant becomes common. Technical complications become apparent during this time, so organ damage that happened during the procurement, stents and anastomotic obstructions, and bleeding complications and leak become very common. Postoperative complications also arise during this timeline, including aspiration, pulmonary emboli, and implanted devices, especially temporary catheters, which can become infected. After that timeline, up to about 6 or 12 months after transplant, there are still some residual technical complications, especially that can persist since the first month. Some undiagnosed nosocomial infections will start to present during this timeline, but community-acquired infections become much more common, and these are some of the ubiquitous ones that I listed here. Cryptococcus, Nocardia, and Aspergillus become very common during this time. Some of the classic opportunistic infections start to appear during this time, including PCP or PJP, pneumocystis jirovecii, pneumonia, and toxoplasma starts to come up at this time as well. Reactivation of latent viral infections is very common if there's no prophylaxis available or if the patient is not taking prophylaxis. So cytomegalovirus, Epstein-Barr virus, herpes simplex virus, varicella zoster virus, and the hepatitis, and BK polyomavirus and adenovirus, and other respiratory viral infections become very common. Some endemic and geographic pathogens also come up, including trypanosomes, strongyloidiasis, and leishmania. And those endemic fungal infections or geographic fungi, histoplasma, coccidioides, and paracoccidioides, should also be on your radar because they will pop up during this timeline. Tuberculosis also tends to reactivate during this time. After that timeline, most patients are really doing pretty well, and their immunosuppression has been gradually decreased or their immunodeficiency has gradually waned. Community-acquired infections during this timeline really dominate. They become very common, especially community-acquired pneumonia, for which the risk never actually goes back to baseline. So viral infections, including influenza, RSV, are very common during this timeline, and chlamydia, mycoplasma, and bacterial pneumonias are also very common. UTIs are more common than the general population, and HSV and VZV shingles can come up. Chronic viral infections do also reactivate during this time, although cytomegalovirus is much less common after this interval. The hepatitis do come up. Fortunately, hepatitis C and to extent hepatitis B are very treatable, and EBV can prevent as post-transplant lymphoproliferative disorder. Chronic anastomotic issues do continue during this time period, and recurrent C. difficile colitis can be a problem. So please have that on your radar. And unfortunately, patients who had poor allograft function start to become evident during this time and tend to require higher levels of immunosuppression, and of course, therefore, are at highest risk of opportunistic infections. Those patients tend to be in the hospital a lot, but be aware that their risk also will never go back to baseline and is much higher than their counterparts who do well with better allograft function. Sort of framed another way, this is a timeline of infection specifically for solid organ transplant, showing it more graphically. On the top, the donor-derived infections, and on the bottom, the recipient-derived infection, and showing the timeline of transplant there at the black arrow on the left. So within the first month are many of the nosocomial pathogens that I mentioned previously, aspiration and catheter infections, and anastomotic issues. And then moving on to 1 to 6 months, we start to see those opportunistic infections arise. This is the highest risk time point at which you start to see those. And again, anastomotic complications do persist. And then after about 6 months or up to 12 months, we really start to see those community-acquired infections dominate, including pneumonia, aspergillus, other molds, and mucor species, and infection with nocardia and rhodococcus does persist. So now that we've talked a little bit about the timelines and some of the types of infections that are common, let's talk about the most common illnesses that we would see in critically ill patients. Severe infection in immune-compromised hosts can be difficult to recognize and diagnose. And I think it's important to remember as we embark on talking about the most common critical illnesses, critically ill patients with infection, that the immune-compromised host is really susceptible to both opportunistic and community-acquired pathogens. So infection can result from exposure to a lower number of organisms than for non-immunocompromised hosts. It's also important to remember that the inflammatory response may be dampened or suppressed in immune-compromised hosts, and they may have attenuated signs and symptoms of infection. Furthermore, by the time they reach care, usually their infections are pretty advanced and they have a high burden of organisms. And so even though they may not appear as ill, they are generally much more ill than our non-immunocompromised hosts. I think what's interesting when we think about immune-compromised hosts is really trying to decide whether it's an opportunistic infection or not, and therefore how broad or narrow to be in our treatment. I hope that the timelines that I provided you with give you some sense, especially acknowledging that that 1 to 6 month window after transplant is the highest risk time for opportunistic infections when you should really consider those the most. Many immune-compromised hosts present with common infections. Common infections are common. However, the difference with immune-compromised hosts is that you have to consider these opportunistic infections as well. Furthermore, immune-compromised hosts, in part because of their history of hospitalization, are generally at higher risk for multi-drug resistant organism infections because they are hospitalized more often and have different exposures. So make sure you're taking that into account and being broader with your antibiotic therapy than you might be in another host. When we're thinking about whether or not an infection is present, we often look for fever. I will say that when you see a fever in your immune-compromised host, it probably is infection. Fever is due to infection in up to 80% of episodes in transplant recipients. So those specific hosts have a very high risk of infection when you see fever. Only about 20% are non-infectious causes, and of those, rejection is a small proportion. And what's also important to remember is that 40% of all serious infections are not accompanied by fever. So you have to have a high index of suspicion, especially for fungal disease, which often does not cause fever. It's also important to remember that febrile viral infections are often due to viruses other than cytomegalovirus, and you should think about other types of infection that I raised earlier in the timelines. So how do we make the diagnosis? If fever is not the main thing that we should look for, we really should have a high index of suspicion, remembering that there's fewer inflammatory signs, that multiple infections are common or multiple concomitant processes, one of which may be infection, that the infection is often very advanced by the time of presentation, so we have to act quickly and to pursue advanced diagnostics very quickly to make sure we don't miss an infection. Antimicrobial resistance is very common, as I mentioned, and the agents that we use or need to use to fight those infections can often have toxic effects. So we want to choose them carefully. And also that often our patients with transplant have altered anatomy, which can complicate our diagnostic and treatment efforts. And remember that the immune deficits are really cumulative with this net state of immunosuppression. So really keep all of that in mind. I also want to add that the timeline of infection for people who've received biologics is often delayed. So we may not have seen them receive the drug within the last few weeks or even months, but it could still be active in their immune system. The biologic half-life might actually be a lot longer than what the pharmacokinetics would suggest. So here's an example of natalizumab, also known as Sabri, which has been associated with PML at a median of 18 months after the first dose. So it's a very long time, and that's not what the pharmacokinetic half-life would suggest. So you can see here how common it is that it comes up late, and I want you to keep in mind that those presentations can occur even in patients who haven't received the drug for many months. So the principles for diagnosis of infection and also for treatment in immune-compromised hosts are the same as for other patients in many cases. However, we really need more advanced diagnostics and earlier. So you should have a lower threshold to initiate cross-sectional imaging to visualize the anatomy, including CT and MRI-based imaging. And tissue is really critical in immune-compromised hosts, especially to get histology. So biopsy is often necessary, and other invasive procedures and special stains are often used to help make these diagnoses. You should really rely more on nucleic acids or proteins for diagnosis rather than serologic tests, because in immune-compromised hosts, the serologic tests are often inaccurate or not useful in acute infection due to their immune-compromised status or to their transfusions. Early and aggressive therapy is really the rule. Source control is of critical importance. I mentioned that these infections are often quite advanced by the time people present, so source control is even more critical than other patients, and there really should be no delay in antibiotics. All in all, though, bloodstream infection and pneumonia are still the most common infections in immune-compromised hosts, and bloodstream infections occur about 18 episodes per 100 patient year, and are most common immediately post-op in transplant recipients, but are still very common throughout the first year after transplant. Pneumonia accounts for 30 to 80% of all infections in solid organ transplant recipients and accounts for more fevers. It's very high in the postoperative period, especially after intubation, and the crude mortality is still very high, greater than 40%. It's also a good reminder that GI symptoms are very common and are often not taken seriously enough, so I don't want you to miss those. Peritonitis and intra-abdominal infections and C. difficile colitis are especially common after liver transplant in the ICU, and those symptoms should be taken seriously. As I mentioned, bloodstream infection is very common, especially in the first year after transplant, and the presentation of sepsis in solid organ transplant and hematopoietic stem cell transplant recipients can be different. Sepsis is still one of the top causes of death in these patients. The incidence is between 20 and 60% of all solid organ transplant recipients, and the mortality is generally higher than that of comparator populations. Severe sepsis in hematopoietic stem cell transplant recipients is about 5 times more frequent than non-immune compromised hosts, and twofold higher mortality is seen in allogeneic stem cell transplant recipients than autologous stem cell transplant recipients. Most infections and sepsis in hematopoietic stem cell transplant recipients are related to neutropenia, so that can be your guide for looking for this risk. An absolute neutrophil count less than 500 or 1,000 with a predicted decrease to 500 that they're on their way down is a risk factor. Mucositis is also a really important risk factor, and delayed engraftment as well. So those can be clues that bloodstream infection might be more common in your patient. What's important to remember here is that patients with solid tumors usually undergo less intense chemotherapy and rarely become neutropenic, making bloodstream infection possible but less likely than the neutropenic population. How does sepsis present in our immune-compromised host? Well, it can present differently, especially in people who've had solid organ transplant. The classic features are often absent, including leukocytosis and fever. Thrombocytopenia and organ failure are often more pronounced, and bacterial infections, as I mentioned, are much more commonly antimicrobial resistant. The most common cause of fungal infections is Candida, and you should have that high on your radar. And they're also at increased risk for opportunistic viral infections, as I mentioned previously, particularly CMV, particularly in that time window of 1 to 6 months after transplant. The management principles are very similar, except that we have to have an even higher index of suspicion and more rapid initiation of therapies and advanced diagnostics. I would encourage you to give antibiotics within an hour. Hang a very good anti-pseudomonal antibiotic. That will be your best friend in treating these patients. And consider using extended infusions of beta-lactam antibiotics. So after the initial dose, which can be given over the usual time frame, consider using extended infusions of 3 to 4 hours to have more area under the curve and time above that minimum inhibitory concentration to kill bacteria. So I strongly encourage that, and the studies that are coming out generally support that. Ensure that there's been adequate resuscitation to restore circulatory volume, and a reminder that our patients probably need earlier and prolonged support of organs. Rapid diagnosis may require more invasive techniques, including bronchoscopy, bronchoalveolar lavage, and biopsies, and source control, as I mentioned earlier, is critically important. I also recommend that you have a lower threshold to remove intravascular devices that could be a source of infection for septic shock, septic phlebitis, or tunnel port or pocket infection. And you definitely need to remove devices when they are contaminated or infected with Staph aureus, Bacillus species, Acinetobacter, Pseudomonas, Stenotrophomonas, Corynebacterium, NTMs, yeast, and mold. One of the questions that I often get asked as an infectious disease specialist is whether mucor or other weird pathogens are the cause of the patient's sepsis. As I mentioned previously, they definitely can occur, and obviously our immune-compromised hosts are at higher risk. However, sudden onset shock and hypotension in a neutropenic patient is almost always bacterial infection, and fungal infection is very rarely the cause of multi-pressure shock. The only fungal infection that really commonly does this is Candida, and that's still much less common than gram-negative rod or MRSA infection. So again, really hanging a good anti-pseudomonal antibiotic is critically important. I wanted to review the pathogens that commonly cause pneumonia in our immune-compromised host and remind you that there's a wider range of pathogens, especially in the context of neutropenia, that can cause pneumonia in these critically ill patients. So are often colonizers that cause this, and in the setting of glucocorticoids, pneumocystis, nocardia, and aspergillus become very common, and so do herpes viruses. In the setting of biologics, especially the TNF-alpha inhibitors, intracellular pathogens can really come out. And for T cell suppression, viral and fungal infections become common. So it's important to remember the net state of immunosuppression and look at those specific contributors for your patient. Also, the epidemiology may be altered by antimicrobial prophylaxis, which I hope your patient is receiving, but be sure that you review that, including how the patient is taking it and whether they're taking it well enough to be protected. In terms of trying to make the diagnosis, history is really the most important thing, trying to understand what immunosuppression your patient has experienced, what their epidemiologic exposures have been, both recent and remote. And remember that a chest x-ray is usually insufficient for the diagnosis of pneumonia in immune-compromised host. Have a very low threshold to pursue cross-sectional imaging, including CT, and for early invasive procedures. As an example, I wanted to show you these images and ask you, which of these patients do you think has a fungal pneumonia? So these are CT images of 3 different patients in A, B, and C. So take a minute to look at this and think about which pathogen you think is causing this patient's pneumonia. This is an immune-compromised patient. We'll say that they're 6 months out from their transplant. So take a minute to look at this and think, is it A, B, or C who has the fungal pneumonia? So in this case, it was actually patient B. Patient A had an E. coli pneumonia, patient B had invasive aspergillosis, and patient C had negative diagnostics and was treated with antibacterials and had resolution of their pneumonia. I think what's really interesting about this case presentation is that all of these patients have somewhat similar imaging findings with a nodule that looks pretty inflamed, a consolidated area that's fairly rounded and has sort of a halo around it, which is often concerning for fungal infection. But I just want to point out that in immune-compromised hosts, that type of presentation can be seen with bacteria as well as fungus. So the imaging alone cannot be your guide, and that's why we need more frequent invasive diagnostics. All right, let's talk about some non-invasive diagnostics that can be helpful, and then we'll talk last about treatment. So there's a great article that reviewed the role of 1,3-beta-D-glucan testing for the diagnosis of invasive fungal infection in adults. I'm going to go through some of those data to help you know how to use these tests in clinical practice. So these have been best studied, the 1,3-beta-D-glucan tests for hematopoietic stem cell transplant recipients and people with leukemia and neutropenia. The use of 1,3-beta-D-glucan is well supported by data in these populations, and they can be used to detect invasive aspergillosis, candidiasis, and some other invasive fungal infections. The data suggests that monitoring patients while they're neutropenic or during other high-risk periods of serial measurements once or twice a week can really help to identify invasive fungal infections early. However, because of the high prevalence of invasive fungal infections in this population, you cannot use a negative 1,3-beta-D-glucan to definitively rule out an invasive fungal infection in these patients. An intermediate or positive test should be worked up, 60 to 80 for the Fungitel or 5 to 11 for the WACO test. And data about testing performance in other immune-compromised populations, including solid organ transplant, are really not very good. The sensitivity is lower in this population, and it has a very low specificity. So that's why it's generally not recommended in those populations. I also want to point out that there can be a lot of false positives. So usually these are low-level false positives, and they're just above the cutoff or maybe 2 times the cutoff limit. Hemodialysis still can cause false positives, as can IVIG and albumin. Cellulose filters, gauze packing, and some specific antibiotics can cause it. Pip/tazo is a classic antibiotic associated with false positives, but it's not limited to pip/tazo, and actually more other antibiotics are much more commonly causing false positives now. And actually, certain bacteria with cellular beta-glucans can also cause false positives, especially Pseudomonas. So people bacteremic with Pseudomonas can have false positive 1,3-beta-D-glucans. It's important to keep that in mind. Again, they're usually low positive levels, which can be a tip-off, but you still have to work it up in your patient, especially if they fall in this population. These are the testing recommendations. So on the left is the patient population, the type of invasive fungal infection that can be detected, whether or not you can use a negative 1,3-beta-D glucan to exclude invasive fungal infection, and then whether you can use a positive glucan to start antifungal therapy for probable invasive fungal infection. So firstly, we can look at hematologic cancer patients, and a negative glucan, as I mentioned, should not be used to exclude invasive fungal infection. It has a low negative predictive value because of the high prevalence of infections in this population. I also want to point out that a positive glucan should not be used to start antifungal therapy in solid organ transplant recipients or other type of immunosuppressed patients. And it's also not recommended in your general ICU population. So I think really this test is best used in hematologic cancer patients, and it's most helpful when it's positive for further workup or for initiating therapy. What about galactomannan? So galactomannan is a polysaccharide and a constituent of the Aspergillus cell wall. It can be sent from either blood or from bronchoalveolar lavage specimens. And the positive results are really very helpful, but not definitive from BAL for invasive fungal pneumonia. The higher level that you use as a cutoff gives you greater diagnostic certainty, and the specificity is pretty high in the lung transplant recipient population. But the highest positive predictive value actually is seen in hematopoietic stem cell transplant recipients, heme malignancies, and granulocytopenic patients. The cutoff is generally used for 0.5, where there's a sensitivity and specificity of 81%, or a cutoff of 1.0 in populations where the incidence is lower, where the specificity goes up, but the sensitivity is lower. So different institutions use different cutoffs. A positive result from blood, however, is relatively specific for invasive aspergillosis, but has a lower sensitivity. And a meta-analysis showed that the cutoff of 0.5 for blood had a sensitivity and specificity around 80%. What you should remember, though, is if your patient is already on anti-mold therapy, the sensitivity will be lower. So keep that in mind and don't let that fool you. False positives also do occur with galactomannan. They're less common than with 1,3-beta-D-glucan. And the most common reasons for false positives are infections with organisms that share cross-reacting antigens. So Penicillium, Fusarium, and Histoplasma are the classics. False positives also occur after hematopoietic stem cell transplant itself, usually within the first 100 days. Patients with mucositis can have false positives. Graft versus host disease patients can also have a false positive. Piperacillin and tazobactam may or may not cause a false positive. Early studies suggested it, more recent studies have not. And IVIG was suggested to cause a false positive in one study. So should we use galactomannan as a screening test? It is suggested that this could help to reduce empiric antifungal treatment compared with a culture-based strategy. The data are still out on whether or not this should be done and the frequency of screening. All right, lastly, let's talk a little bit about treatments. So I want to mention that when you're thinking about treatments for infections in your transplant patients especially, you really need to think about drug-drug interactions. So the azoles will increase tacrolimus levels and cyclosporin and rapamycin. So you should really be cautious about drug interactions, work with pharmacists, and monitor those levels closely. The rifamycins decrease tacrolimus levels and increase prednisone levels, so could actually increase your immunosuppression. So again, work with pharmacists and be very cautious. QT prolongation is also very common because many of these patients are already on QT prolonging medications, and you want to monitor that closely, especially in patients with liver disease. So I recommend using an online drug interaction calculator, or even better, working with your pharmacist. I also want to remind you that prevention is really the best treatment in immune-compromised hosts. Ensure that all of your patients are vaccinated at the earliest time interval before their transplant to make sure that those vaccines have the greatest efficacy. Ensure that your patients are really on their prophylactic medications and taking them correctly. For PJP or pneumocystis pneumonia prophylaxis, Bactrim is strongly preferred. Atovaquone and dapsone can be used, but they tend to be less effective. Make sure your patients are taking acyclovir if that's indicated to prevent viral infections from coming back, and ensure that they're undergoing routine monitoring and that early intervention is the rule, that you're not sitting on patients too long before working them up. A few other pearls about other infections. Just remember that Aspergillus after COVID-19 is still rare, but something to think about. That Cryptococcus does occur, especially in patients with liver disease, even if they don't have other immune suppressive factors. So you can see that in your critically ill hosts, and the immune compromise there is just their liver disease. If you see lung and brain lesions together, think about Aspergillus and nocardia as common causes of those. Remember that PJP can be very common in post-transplant patients and very severe, and that your severely immune-compromised patients can have more than one thing, either two infections, multiple infections, or infection plus something else that's co-occurring. There's many good reviews on this topic that I would encourage you to read to get a little more in-depth information. I put a couple of those references here, and I think you'll enjoy reading them. This is a great one about invasive fungal infections and targeted therapies that I would encourage you to read as well. Lastly, I've included a couple of those charts that I mentioned earlier about the specific effects of biologics and what can happen so that you can really think about them, especially if your patient is taking combination biologics. So both of these tables, I think, can be quite useful in thinking about the risk for invasive fungal infection and other infections and whether or not your patient might need prophylaxis against those. So the cardinal rules are that immunosuppression and infections are not always straightforward in immune-compromised hosts. Be prepared to be surprised, think broadly, but common things are still common. And prepare your patient for immunosuppression, give vaccinations, remember to involve your infectious disease consultant. And prophylaxis and vaccines alter that risk equation that I mentioned. Primary and secondary prevention are extremely important, and consider the source of infection according to your timeline and your geography. So lastly, our take-home points once again, remember to consider the net state of immunosuppression from all of the contributors. Remember that timeline really matters, and community-acquired infections are very much more common after about 6 to 12 months after transplant especially. Sepsis remains a leading cause of death in immune-compromised hosts, and pneumonia risk persists essentially forever and never goes back to baseline after a transplant. Have a very high index of suspicion. Remember that immune-compromised hosts have more subtle presentation. Common things are still common, but multi-drug resistant infections are much more common in immune-compromised hosts than the rest of the population. Have a low threshold for advanced imaging and invasive diagnostics, and remember that prevention is key. So thank you very much for your attention, and I look forward to hearing from you.